Hi, so I just want to apologize in advance for the funky looking screen. It's just the only way that I could get myself and my presentation on the video at the same time. I also apologize if I have to cough or blow my nose during the presentation because I am a little sick. So, with that being said, the objectives of the presentation are to review the etiology of the Epstein-Barr virus and the cytomegalovirus, review any pertinent physical findings, distinguishing factors, and then discuss treatment on patient education, and then review some current research. So, mononucleosis, often called mono or the kissing disease, is a contagious disease that is common in teenagers, young adults, and college students, mostly because of the ones going around kissing lots of people. Mono is most often caused by the Epstein-Barr virus, or EBV, but may also be caused by the cytomegalovirus, or CMV. CMV is a common pathogen that approximately 40 to 100% of the population has been exposed to, almost 100%. 20% of children will have contracted this virus before puberty or be reinfected with a different strain. CMV is part of the herpes viridae group, which also includes the Epstein-Barr virus. CMV can remain latent in the host but reactivate when the immune system is compromised. So the Epstein-Barr virus is a widely disseminated herpes virus that is spread through intimate contact between susceptible persons and EBV shedders. Humans are the major reservoir for this virus. EBV and other viruses that cause mono, such as CMV, are spread most commonly through body fluids, but most often saliva. However, these viruses may also be spread through blood, semen, blood transfusion, and organ transplants. Approximately 90 to 95% of adults will eventually be EBV seropositive. In developing countries, the EBV seroprevalence rate is close to 100% by the age of 4. In low socioeconomic areas of the United States, this percentage is approximately 25 to 50%. Most cases of EBV acquired during childhood are subclinical, with less than 10% of these children showing symptoms. The incidence of symptomatic cases begin to rise during adolescence and through the adult years. Following an infection with mononucleosis, the virus may be shed in the salivary secretions at high rates for an average of 6 months after the onset of illness. However, it has been noted that this shedding may occur for decades after the illness has resolved. When EBV is introduced to the oropharynx through kissing or by other means, the virus begins the replication process. This virus has a high affinity for B cells for the lymphoid tissue, thus the infection spreads throughout the lymphatic system, causing severe lymphadenopathy. The body reacts by developing antibodies against the virus. In 90% of cases, heterophile antibodies are produced in response to the infection of EBV. Infection with EBV is lifelong with periodic reactivation. In poor immune response systems, there is a small risk that the virus may induce Hodgkin's lymphoma. Similar to EBV, CMV infection is usually inapparent. As with other herpes viruses, CMV can remain latent in the host and reactivate or shed when the host's immune system is compromised. CMV is not highly contagious, but is contracted from close personal contact with people who excrete or shed the virus. CMV is also shed in the saliva as well as urine, blood, breast milk, semen, and throat and cervical tissues. Initial infection is typical in newborns and is then reactivated when the person is immunocompromised. CMV is a big issue in patients who have received organ transplants, as they are often immunocompromised, making them more susceptible to the serious symptoms associated with this infection. Family practice providers are most likely to encounter CMV when a patient presents with an infectious mononucleosis syndrome. 5 to 7% of immunocompromised patients with an mononucleosis type syndrome will have a CMV infection. Classic symptoms of mononucleosis include extreme fatigue, fever, sore throat, head and body aches, swollen lymph nodes, pharyngitis, enlarged spleen or liver, and a rash. Fatigue is often severe and may persist for a number of months. I actually had a friend in high school who got mono. We were in dance together, and one night after our ballet class, she was driving home. She lived about 20 minutes out of town, and the fatigue was actually so severe that she fell asleep at the wheel and ended up rolling her car. So that just kind of goes to show how severe that fatigue can get for mononucleosis. Lymph node involvement is typically symmetric and more often involves the posterior cervical and posterior auricular chains. Lymphadenopathy may also become more generalized, which is oftentimes a distinguishing factor from other causes of pharyngitis. Lymphadenopathy peaks in the first week, then subsides over the next 2 to 3 weeks. Tonsillar exudates may also be present and can appear white, gray-green, or sometimes necrotic. Palatal petechiae with streaky hemorrhages and red macules are occasionally present, but is more often seen with streptococcal pharyngitis. Splenomegaly is seen in approximately 50 to 60% of patients, but often resolves by the third week of illness. Splenic rupture is a rare but potential side effect or complication of mononucleosis. A morbilliform rash is a common complication of mononucleosis and needs to be distinguished from an antibiotic reaction rash commonly caused by penicillin or other like antibiotics. The most common laboratory finding with mononucleosis is lymphocytosis, which is defined as an absolute count greater than 4,500 per microliter, or on a peripheral smear, a differential count that is greater than 50%. A peripheral smear may also identify atypical lymphocytes, which is defined as more than 10% of the total lymphocyte count. The total WBC count in patients with infectious mononucleosis ranges anywhere from 12,000 to 18,000 microliters. Thrombocytopenia, neutropenia, and hemolytic or aplastic anemia are other common laboratory findings. Elevated liver enzymes are seen in a large group of patients. Therefore, abnormal liver function tests in patients with pharyngitis strongly suggest a diagnosis of infectious mononucleosis. Distinguishing whether someone is presenting with a CMV or EBV-induced mononucleosis can be very difficult, as the presenting symptoms are very similar. Malaise, fever up to 103 degrees Fahrenheit, chills, sore throat, headache, and fatigue are the primary features of both viruses. The possibility of an acute CMV infection should be investigated if a negative heterophile antibody test or monospot rules out EBV-induced mononucleosis. So in patients who present with fever, pharyngitis, lymphadenopathy, differential diagnoses to be considered include group A strep, CMV infection, acute HIV infection, toxoplasmosis, EBV infection, acute viral hepatitis, human herpes virus 6, and lymphoma. Although toxoplasmosis is uncommon, if the patient is pregnant, severe adverse effects on pregnancy outcomes may occur. Therefore, this differential needs to be ruled out in women of childbearing age. Streptococcal infections are not usually accompanied by significant fatigue or splenomegaly on examination. Pharyngitis that is due to a CMV infection is typically mild if present at all, but may cause liver enzymes to be elevated. Infection with EBV also causes liver enzyme elevation. Diagnostic testing is needed to differentiate between CMV-induced mononucleosis and EBV-induced mononucleosis, as well as an acute HIV infection. Splenic rupture and airway obstruction are common but severe complications of mononucleosis. Airway obstruction upon examination requires immediate action. Obstruction is often due to lymphadenopathy and mucosal edema. Severe obstruction may be treated with a tracheotomy or endotracheal tube, as well as any other advanced airway. Corticosteroids may be used to combat pharyngeal edema and lymphoid hypertrophy. Splenic rupture is also potentially fatal and requires immediate and emergent intervention. Treatment for a splenic rupture depends highly on the patient's status. Things to consider include the grade of injury, presence of other injuries, medical comorbidities, and the hemodynamic stability of the patient. Management options for splenic rupture include observation, angiographic embolization, or surgery. Other potential serious complications of an Epstein-Barr virus infection include Guillain-Barré syndrome, nervous system complications, pericarditis, pneumonia, and hepatitis. Here is a table that I found on the American Academy of Family Physicians website. I thought it was extremely helpful. It just kind of has that list of most of the differential diagnoses that I listed, but then it has the key distinguishing features to kind of help differentiate between the two and roll your diagnosis down a little bit. So up to 98% of patients with mononucleosis will have a sore throat, lymphadenopathy, fever, fatigue, and tonsillar enlargement. 85% of people will present with pharyngeal inflammation, and 55% will present with transient palatal petechiae. Children may present with nonspecific or no symptoms, which often leads to an inaccurate diagnosis. Older adults have a higher likelihood to present with jaundice, whereas this only occurs in 8% of young adults. To help narrow down differential diagnoses, the provider should ask the patient about generalized symptoms such as fever, chills, weakness, fatigue, and weight loss. Asking the patient about nausea, vomiting, abdominal pain, and tenderness on palpation are also helpful points to gather due to the hepatomegaly and splenomegaly that may be present with mononucleosis. Asking the patient about risk factors of mononucleosis, such as kissing or engaging in other sexual behaviors, is important. The skin should be assessed during the physical exam, as a morbilliform rash is common in those with mononucleosis. The provider should also ask about coughing, shortness of breath, photosensitivity, loss of appetite, myalgias, cognitive difficulties, and difficulty concentrating. Asking the patient if they have recently consumed undercooked meat or cleaned a cat's litter box is helpful when ruling out toxoplasmosis. So the diagnostic test that should be ordered. Sorry, give me a sec. So evaluation of the patient should first include an assessment of the airway, as well as hemodynamic stability to rule out a splenic rupture. Lab work should include a CBC, CMP, monospot test, and antibody testing. A CBC will often reveal lymphocytosis with a differential greater than 50%. Leukocytosis and thrombocytopenia may also be present. The laboratory findings include atypical lymphocytes, fewer than normal neutrophils or platelets, and abnormal liver function. The monospot test or heterophile antibody test is a diagnostic test of choice and is nearly 100% specific. However, the sensitivity is only about 85%. If the patient is in the early stage of the illness, the test may be falsely negative and should be repeated later. Heterophile antibodies are often not present in children with infectious mononucleosis, therefore it would not be detected on this test and lead to an inaccurate diagnosis. Rapid antigen testing or a throat culture should be ordered to rule out streptococcal infection. Antigen testing for Epstein-Barr virus includes the viral capsid antigen, early antigen, and EBC nuclear antigen. The possibility of an acute CMV infection should be investigated if the heterophile antibody test comes back negative, therefore ruling out EBV-induced mononucleosis. The best test for establishing a diagnosis of CMV mono is a serology for the CMV IgM antibodies. This test result should be positive in patients during the symptomatic phase of the illness. However, these antibodies may not reach detectable levels until 4 to 7 weeks into the course of the illness. IgM antibodies produced in response to a CMV infection may remain elevated for up to 1 year or longer following the acute infection. And then here's another helpful diagram that I found. It just kind of shows the lab work that you would order and how that kind of how those results lead to a more defined diagnosis. So as you can see, if that the heterophile antibody testing is negative, that would immediately lead you to look at the CMV infection, and then whether that's positive or negative, you kind of have to go from there, but I thought it was helpful. So the treatment for EBV-induced mononucleosis and CMV infection consists primarily of supportive care. Adequate hydration, rest, and good oral intake should be encouraged. Antipyretics and NSAIDs may be helpful in treating fever, sore throat, and the general fatigue that is seen with this illness. In cases of airway obstruction, corticosteroids are indicated along with proper airway management. Corticosteroids should not be used if a compromised airway is not present, as corticosteroids may lead to further immunosuppression. Acyclovir is a nucleoside analog that inhibits permissive EBV infection through the inhibition of DNA polymerase, but has no effect on latent infection or the ability to cure the infection. Several short-term studies have shown that acyclovir may suppress oral viral shedding, but significant clinical benefits have not been found. A referral should be considered if the patient has fever, night sweats, weight loss, splenomegaly, bruising, and lymphadenopathy in the supraclavicular, popliteal, or iliac region, as this may be suggestive of a more serious diagnosis such as leukemia or lymphoma. I was unable to find any specific referral recommendations, but obviously if you had a patient that you were concerned that they maybe had a diagnosis of leukemia or lymphoma, you would want to immediately refer them to oncology. So moving on to our research articles. So the first study that I looked at was a Cochrane review from 2012 that looked at the safety and efficacy of corticosteroid use for symptom control in those with infectious mononucleosis. So in this review, 7 trials were included. It was a heterogenic review which prevented a combined analysis of the data. 4 of the 7 trials looked at the effectiveness of short-term steroid use for symptom control in comparison to a placebo. The other 3 trials looked at a combination of steroid and antiviral drug therapy. In total, this review included 362 participants and found that there was no clear benefit for corticosteroid use in regards to recovery. Therefore, it is not recommended, mostly because of the lack of clinical benefit and the risk of further immunosuppression. So the next study that I found was conducted in Hong Kong in 2018 by the Infectious Disease Society of America. The study was a 14-year retrospective study that looked at trends in CMV seroprevalence rates. So CMV infection rates in those ages 18 to 45 increased from 14.5% in 2004 to 32.2% in 2017. This led to a higher incidence of CMV mononucleosis. One possible reason for the increase in CMV incidence may be due to the increasing amount of mothers who breastfeed. It is well known that CMV is expressed through breast milk, so that kind of leads to exposure early on in life. The other most common risk factor for acquiring primary CMV infection was found to be household contact with younger children who had the virus. This was consistent with a previous study that found that children are viral shedders for more prolonged periods of time, so they place immunocompetent adults at a higher risk, therefore increasing the amount of CMV prevalence. Third study that I want to look at is also a Cochrane review from 2016 that looked at antiviral medications for the treatment of infectious mononucleosis. Mononucleosis caused by the Epstein-Barr virus is not generally a serious disease, but it may lead to significant time away from work or school just due to the amount of fatigue that these patients experience. This review included 7 studies as well and consisted of 333 people in total. 3 different antiviral drugs were studied, and they included acyclovir, valmiciclovir, and valacyclovir. Outcomes that were investigated included the time of recovery, medication side effects, how long it took to eliminate the virus from the throat, days off of school or work, economic outcomes, and the duration of fever, sore throat, lymphadenopathy, splenomegaly, and hepatomegaly. There were no huge adverse effects related to this drug administration. However, the recovery time improved by 5 days, but this measurement was not super precise. The time taken for the lymphadenopathy to resolve improved to approximately 9 days, but once again, this measurement was not concise throughout all trials, making it kind of inaccurate. So in conclusion, 2 of the 12 areas, they did see improvement with the administration of antiviral therapy. However, the effectiveness of antiviral therapy is not clear. Potential adverse effects, costs, and antiviral resistance should be considered before implementing this type of treatment. So, patient education. Because mononucleosis typically affects teens and young adults, many of these patients may participate in sports. More than 50% of patients with infectious mononucleosis will develop splenic enlargement. So the biggest concern following diagnosis is avoiding activities that may precipitate a splenic rupture. Splenic rupture is most likely to occur within 2 to 21 days of symptom onset. Rupture after the 4th week is pretty rare. Contact sports such as football should be avoided for 21 days at least, but some recommendations say to give it a full 4 weeks. For those who participate in non-contact sports such as dance, golf, anything like that, training may begin after 3 weeks of onset, but it should begin with a more mild intensity and then gradually increase as the patient is starting to feel better. For activities that are strenuous, such as weightlifting, intra-abdominal pressure may be increased. Therefore, these activities should be avoided for a minimum of 4 weeks, as this may also cause a splenic rupture. There are currently no vaccines for CMV or EBV. Therefore, prevention should be aimed at avoiding sexual contact or kissing those who are known to be infected. However, this can be very difficult because, as I stated previously, up to 90 to 95% of the population is a carrier of this virus or a viral shedder. But according to the National Institute of Health, there have been recent developments in the creation of a vaccine targeted towards the Epstein-Barr virus. A research team from the National Institute of Allergy and Infectious Disease determined how several antibodies induced by the Epstein-Barr virus block the infection of cells that were grown in the laboratory. EBV is linked to cancers of the epithelial cells, specifically in the nasopharynx and gastric regions, as well as Hodgkin's lymphoma, therefore resulting in 200,000 cases of EBV-associated cancers annually. This new research team found that the antibodies on these viral proteins called the GHGL complex may play a role in the inhibition of EBV's fusion with epithelial cells. The vaccine was tested on mice and monkeys, and they found that in both of these animal models, the vaccine induced antibodies that significantly inhibited epithelial cell fusion. So this team is currently planning to develop a vaccine that is more focused on human trials. And so hopefully this is something that our class will be able to see in the future as we're treating patients and will be able to offer. Mononucleosis, whether it's caused by EBV or CMV, can take a great toll on patients who contract these viruses. Over half of the population will be infected with CMV by age 40, and 90 to 95% of those 90 to 95% of the population will be infected with EBV at some point in their life. Because most of these people will not show any signs or symptoms, it makes prevention pretty difficult. It's important for providers to recognize the distinguishing factors of mononucleosis compared to other diseases like streptococcal infections and HIV. Laboratory testing is extremely helpful in establishing a diagnosis. Patient education should focus on the risk of splenic rupture and the importance of avoiding sporting activities until the specified time. Patients should be managed using supportive measures and preventing the continuous spread of infection as much as possible. And then here are my discussion questions that will be posted later, and then my references. So thanks for watching.